Okay, so we're gonna be going over chapter 37 as the first chapter being infections. So there's a few things that I noticed that Dr. McCrink liked to ask about, and I do notice it come up a lot on like the proctored ATIs that I take. So I definitely see you guys getting a few questions on it. I do remember getting tested on it about vaccines. Now you don't need to know every single vaccine and every one that's administered and when. She definitely does not expect that from you, but the ones that she highlights for you as she goes along and maybe mentions, hey, this is given at this time, you should know that. But there's also some really important points about vaccines that you should know. One being that a person who is immunocompromised should not get a vaccine. So if they have any sort of, live like they have an infection, they're a cancer patient, right? They have an autoimmune disease, they cannot get live vaccines because the live vaccines actually contain remnants of the actual virus or the bacteria. So someone who's immunocompromised cannot get live vaccines. So immunocompromised patients cannot have any sort of live vaccine. And some vaccines are live and some aren't. So what you have to know or be able to recognize which ones would be live or considered like and which ones wouldn't be. Children who are under the age of 1 do not also receive live vaccines or viral vaccines. Another thing is that if they have, a mild illness, right? Like they have a little cold or something, right? Nothing too crazy, would not be a contraindication for getting immunizations. And things like swelling, mild aches, pains, and redness are not considered contraindications or I quote unquote allergies to medications. So if they say they got a little bit of redness, maybe in the area that it was in, maybe they have little aches there, pain, slight swelling, that's not considered an allergic response to a vaccine. If they're having some sort of, anaphylactic reaction where they feel their throat closing, yes, that would be contraindicated. So anything that has to be respiratory related would be contraindication. Anything else wouldn't really be considered a contraindication for receiving a immunization. And if they do have an anaphylactic reaction, we want to give them epinephrine 1 to 1,000. Um, if we do notice any signs and symptoms of respiratory distress. So those are a few things that you want to know, right? For vaccines, I think she either gives like a select allowed apply or ask a few of these questions along the way, but definitely know that and that you can give more than one immunization at a time, depending, of course, on the vaccine, but you could give more than one. Another thing is that there's a few vaccines that you should know when they're given, and she does ask about that. So, for example, when a baby is born, the first vaccines or one of the first vaccines they get is hepatitis B. That's the first thing that you get when a baby's born within that first 24-hour period. At 6 months of age is the earliest in which a baby can get the flu vaccine and the COVID-19 vaccine. But remember, there's some flu vaccines that are live and some that aren't. So it would be the not live one. Because as we said, no living vaccines before the age of 1 or if they're immunocompromised, right? Some examples of live vaccines include the measles, mumps, and rubella vaccine and the varicella vaccine. Those they can get after the age of 1, but before that, no. You also need for vaccines the name, the dose, the site, and the lot number. That's what you need to document when a vaccine is given, and I would know that because she does ask that. So those are a few different things that you should know about vaccines. Um, Another thing that I want to talk about is medical treatment, specifically when it comes to having any sort of illness. So when someone's sick, there's a few different things we want to do, especially when they have a fever. We want to reduce the fever, and one of the best ways to do that is hydration. I know Dr. McCrank, when I had her, emphasized when someone has a fever, one of the best things that we can do is encourage fluids. Keep giving them fluids. especially because when they have a fever, you lose fluids due to insensible losses such as sweating, right? Your temperature's going up, things like that. So we want to make sure we hydrate them. And we always want to have techniques to reduce the fever, right? So antipyretics, like acetaminophen. Remember, no aspirin for children. We talked about the one disease where you could give it, but no. Other things could be removing blankets, right? Making sure they could use cooling blankets, but not warm blankets, right? Lightly dressed, nothing too heavy, because that's going to increase their body temperature. If they have shivering, um, we don't want to induce shivering, because shivering means that it's going to make them very uncomfortable. So we don't want to do anything that's going to increase that, right? So if we make them too cold, they could start to shiver, and that could be really uncomfortable, and things like that. So just know that we want to reduce the fever, right, through different methods. We could use meds or non-pharmacological methods, but hydration is one of the priorities when it comes to fever reduction. So, we have a few different bacterial infections, and one of them is strep throat slash scarlet fever. Now, we did speak about going back to GU, right? Acute post-infectious glomerulonephritis, which has to do with having a strep infection, right? So if they have a strep infection that was not treated, it can cause them to potentially go into, acute glomerulonephritis, temporary kidney problems. So this is where it becomes really important to educate the parents of the child who has strep throat, because of the fact that it can turn into that, right? If they don't fully take the course of antibiotics and things like that. But strep throat is typically caused by a group A beta hemolytic strep or streptococci. It typically causes painful swallowing and usually will not have a fever, but they could, but no, usually not. Scarlet fever is a bacteria that produces this toxin, which also leads to this rash, and they will have an abrupt fever. So strep throat, think, okay, painful swallowing, right? It's in the throat, it's swelling, but it's not going to really cause a fever. If there's a rash and a really high fever, we're thinking about scarlet fever, and that's the difference between the two, because they're both going to have a sore throat. Other things is that we need to tell the family that your child is going to be infectious until 24 hours after they start their antibiotic treatment. So, in other words, they cannot go to school until they have taken their antibiotic for 24 hours. After that, they're not infectious and they can go back to school. They can go back to doing the things that they were. But when they're taking antibiotic therapy, they must have it in their system for the first 24 hours before they can go and see people. Next is, how do we diagnose? Well, we have a rapid strep screening. So if it's positive, automatically comes back, right? You know, the strep test, they put it in the throat, they swab it. I think it's particularly annoying. I don't like it. But if when they do that, if it comes back positive right away, we're going to treat it with antibiotics. If it comes back negative, they send it back for a culture just to make sure, you know, in case sometimes it can be a false negative. So we'll send it for a culture just to confirm that it's negative. But obviously, if it's positive, right straight to the antibiotics. So as I already talked about the differences between strep throat and scarlet fever, just to get a little bit more in depth. So scarlet fever specifically, as I said, we have that fever. So they're going to have a severe sore throat with a fever of greater than 101. They'll have a headache, stomach ache, rash, right? They'll have really enlarged and tender lymph nodes, like the tonsillar lymph nodes, and they could have a strawberry tongue. Other things that are characteristic specifically of the rash is that it's going to be really red, or having a lot of arrhythmia on like the face, the trunk, the extremities. It's almost going to look like a sunburn, and it's going to feel like sandpaper. Another clue is that they're not going to have nasal congestion, right? So with strep, they may have a little bit, but with scarlet fever, no. And they're also going to have something called desquamation, which is when the hands and the feet, they start to peel, right? Almost like, when you get a sunburn, or if you've ever had a sunburn or seen someone with a sunburn, sometimes the skin starts to peel. Think about something like that, right? So when it gets really red and then it starts to peel as a result of the burn, that's kind of what happens here. For nursing management, Once again, we teach them, right, to take the full course of the antibiotics, because as we've learned, if they don't, they're at risk for that acute post-infectious glomerulonephritis. Usually penicillin type antibiotics are the drug of choice. No school for at least 24 hours after antibiotics. And also we should tell them they should not be going to school if they're still having a fever while taking the antibiotics. We want to manage the fever, use cool mist humidifiers for like the sore throat. That's really going to help with comfort. Having fluid intake. Remember, anytime there's a fever, you always want to manage it with good oral intake of fluids, soft foods, because think about it, right? If their throat is really sore, we don't want to give them anything that's hard and rough. So soft foods, warm liquids is going to soothe the throat, not hot, not cold, warm. And make sure that they replace the toothbrush. That's another thing that we want to tell them, because it's still going to be bacteria on it. So once the infection goes away, replace the toothbrush. Another thing that we have is pertussis. Now, pertussis is also a bacterial respiratory infection. I think for your notes, it's very good to separate what's bacterial, what's viral, so that you know as the nurse what I should be giving antibiotics, or what should I be teaching them about antibiotics versus what are viral infections, because we know we don't give antibiotics to viral infections. But pertussis is an acute respiratory infection. And you've probably heard about this before. But this is an upper respiratory infection. And you'll usually hear this whooping cough, which could also be defined as paroxysmal coughing, which we call the whooping cough, and they have a lot of secretions. So the treatments for this bacterial infection is antibiotics like azithromycin, erythromycin. We're not going to give penicillin type. So that could be another thing to point out, because she will ask about meds to know which one would I give a penicillin type versus which one I might give erythromycin to, and azithromycin and things like that. And respiratory support, because this is a respiratory complication. So if we know this affects the breathing, we need to give respiratory support. The CDC recommends that all close contacts are treated with antibiotics. So we want to inform the parents that if their child has pertussis, that they should also be taking antibiotics. And thinking that this is respiratory, your priority assessment is going to be respiratory. So we're looking at breath sounds, respiratory rate, O2 saturation. Are they having retractions or nasal flaring, which is going to indicate that they're having some sort of respiratory distress, right? We want to put them on droplet precautions. So we want to make sure that we wear a mask when we're in close contact with them. And if we take them out of the room, they wear a mask. That they have a good immunization history, that they should be up to date with those. See if they have a history of an upper respiratory tract infection previously, because that could have what caused them to obtain this bacterial infection. The high humidity environment is good for them, because it's going to help actually remove those secretions. Chest PT, post-dural drainage, all of those can help with mobilization of the secretions, as well as suctioning, encouraging fluids, and making sure they take their antibiotics. Another bacterial infection is osteomyelitis. Now, this is an infection that gets into the bone, right? Especially those joints, and it's very painful. And it's usually caused by a Staph aureus infection through the break in the skin, right? So, for example, a surgical patient who's maybe getting, a knee or a hip arthroplasty could be at high risk for osteomyelitis, because you're doing a procedure in which is really affecting the bones, right? So when I would study, sometimes I had to make little like mnemonics. So I use Pew. I don't know why, but for me, it was pain, edema, or arrhythmia, and warmth. That's how I remembered the main symptoms that you would see: pain, edema, or arrhythmia. It goes both ways. And warmth, as well as they have a fever, because remember, infection, we're thinking about fever. They're going to have leukocytosis, which just means an increase in white blood cell count, which makes sense because that's the response to having an infection in the body. They're going to have decreased movement. And that's because imagine you're having, right, inflammation and infection in the area of the joint, and joints allow your bones to move. So it's going to hurt to move, especially the area in which the infection occurs, right? And they're also going to have an elevated sedimentation rate, which basically just means inflammation in the body, right? So diagnosis is going to be a culture and sensitivity, because we're looking for that Staph aureus. We're looking for a CBC to see the elevated WBCs and also an X-ray of the affected site. So because we're thinking bacterial, we have to do antibiotics, analgesics, right? Such as ibuprofen, and ibuprofen because it's anti-inflammatory. Those would be better because this is an inflammatory response, as we've seen with the elevated sedimentation rate, and antipyretics. We want to support the extremity and a high protein diet because high protein enhances and quickens healing. Any questions about any of that? Hey. So those are the common bacterial infections, and now we're gonna go into viral infections. So varicella is a viral infection. Now, we know that immunity could be either from getting the disease itself, getting cured from it, right? Um, or you get the vaccine, right? But remember, we said this vaccine is a live vaccine, so we do not give it to children under the age of 1 or anybody who's immunocompromised, and pregnant women. I don't know if I said that before, but pregnant women also never receive live vaccines. Another thing is that these patients are typically infectious 1 to 2 days before the onset of the rash. So, even though all those lesions could look dried up and crusted over, that doesn't mean they're not still infectious. Manifestations include a mild fever, anorexia, malaise, or like feeling tired. They might have a headache, but they're gonna have this really highly pruritic or itchy macular, papular, vesicular rash. The reason I mention all of these terms, like why am I mentioning all of them, is because they kind of look different. They have all of these all together. So they can look papular, they can look macular or vesicular, like a blistery like. So they kind of look different. There's a bunch of different like little bumps around their body. It's not just one type of rash. So that's something to think about. So if you see in the question, oh, a child presents to the ED with a mild fever, anorexia, and lesions of varying degrees, that would make me think this patient might have varicella, right? So, to manage it, because it's a very itchy rash, we want to do oatmeal baths and calamine, I'm sorry, I'm probably saying it wrong, lotion. Those are going to really help with the itchiness. Antihistamines, such as oral Benadryl, but we have to monitor response, especially for Benadryl, because it can cause this sort of paradoxical effect because even though Benadryl can be sort of tiring, it could also cause you to be hyperactive. So even though you might be giving it to your kid to help with the inflammation, it could either make them tired or hyperactive. So it really depends. Also antipyretics if that fever, right, is really high, like if it's over 101. And this is our airborne precautions, okay? So make sure you know that for these patients, right, you need an N95 and things like that when you enter the room. Other things is that they could have complications because remember, we're talking about these lesions. We're talking about open lesions that could burst, right? So from scratching or just, them opening up, you can get a secondary bacterial infection of the skin. They can get permanent scarring, especially if they scratch them a lot and keep opening them. They can have encephalitis or which would be inflammation in the brain, right? They could also have Rye syndrome from aspirin, another thing that we need to watch out for, which is why we do not give aspirin. And they can actually get like a lifelong illness later on in life called shingles. So you can only get shingles if you've had chicken pox. So we want to educate, especially the family, that this child could potentially get a shingles infection later in life as a result of having being exposed to this viral infection and getting varicella. Okay. Another viral infection is arrhythmia infectious, or what we call the fifth disease. So, immunity can be from either naturally you get exposed to it, get over it, but there's no vaccine for this one. It's very contagious before the onset of symptoms arrive because you don't need to have any symptoms. If you're exposed to this, it's very infectious. Um, the period actually is thought to end at the time the rash appears. So, once the rash starts coming, they're probably not infectious anymore. But that prodromal period, or like that before the rash starts to get on, they'll have a low grade fever, a headache, maybe a mild upper respiratory infection, like maybe like little sniffles, right? If they're starting to experience that, they're in this infectious period, right? Other things that are characteristic of this particular illness, and I also have a picture on the right side where like you see where the cheeks are really red. And that's because it almost looks like a slap on the cheek, the rash. That's how red it is. So it's a really intense fire red edematous rash on the cheeks. It looks like the little kid was slapped, but they weren't, but it looks like that. Um, there's also like this maculopapular rash that can spread on the trunk and the extremities. It's really red. It has like this lacy appearance. Um, and it basically the rash starts upper and it moves towards the trunk. So it goes from like the face and down towards the trunk and the extremities. Um, Basically the management is just monitoring the temperature and encouraging fluids. There's not really much more you can do for this child other than that. Um, the next one is the hand, foot, and mouth disease. Now, this is typically common in children under the age of 10, and they can get it more than once. The manifestations include a really high fever is usually the first indication. So let's just say like 102, right? And then they have these small vesicles that appear in the mouth, the palms of the hands, and the feet, and they're like these shallow little ulcers, okay? These are the pictures. So you could think hand, foot, and mouth disease is there's ulcers on the hand, feet, and mouth, and they cause a fever. They're also at risk for anorexia and dehydration because imagine you're having little ulcerations all around your mouth or in your mouth here a little bit, right? That would be very uncomfortable. You might not want to eat or drink much because it hurts. So as a result, they're at risk for dehydration and anorexia from lack of proper nutrition. So the priority for these patients is nutrition, and that's because they may not be eating. So we want to give them bland, soft foods and non-acidic drinks. Hand hygiene, make sure you have really good hand hygiene. They clean the surfaces that the child touches, and because they're gonna have a really high fever, um, treat it with acetaminophen, ibuprofen. Also, something interesting about hand, foot, and mouth disease is that you do not have to be a child to get this disease. I've actually known people who've gotten exposed to this from a child who had it. So you could be an adult and catch this disease, and it's going to look very similar. You're going to see things on your hands and your feet. Um, and yeah, it's very painful from what I've heard. Um, Okay. Now I'm a fan of charts, if you haven't noticed. I think when I have charts, I get to like see things better, especially in diseases that I find or disorders that are more similarly related or sound alike, spell alike things. So I try to put everything together. So I made a chart for rubella, which is also called German measles, measles, which is called rubeola, and then extem subitem, which is roseola, or what we call sixth disease. One, because they almost all look very similar, and also because the symptoms are very similar as well. So, first, let's talk about rubella. Now, rubella is also viral, right? It's a natural, you can either get it naturally, right? You get exposed to it, or you can get immunity through having the live vaccine. It's a pink macular papular rash that begins on the face and the scalp and the neck and spreads down to the toes. So I think it goes from up to down, okay? Now, this rash, as it starts to spread, it begins to fade, right? So when it's on the face and it gets to the trunk, it's going to fade from the face bit to here, right? It's going to fade as it goes down. It's also going to be a low grade fever. They're going to have like really tired, have a sore throat, and a cough. Um, Other things that they're gonna have is different treatment methods. So we know that this is going to be droplet precautions. They're going to need antipyretics and antipuritics, so things to help them stop itching. But a really big concern is that, especially let's just say the person who is exposed to this illness is very young, or this happens during pregnancy, which we call intrauterine exposure or congenital rubella, can cause deafness, growth retardation, And this can be really, really bad for the child. So this can affect their growth and development. So that's why we have to be very careful with the pregnant women and educate them on not going near people who are sick, because if they get exposed to rubella, especially if they don't have the vaccine, right, this could affect the child and affect their growth and development. So definitely know this, right? And of course, these are droplet precaution patients. So that's another thing that you want to keep in mind. Um, the next thing is measles, right? Now, rubella could be called German measles, but measles is called rubeola. So a little difference. I see a hand raised.
Um, what does LAD mean? Oh,
I'm trying to think. I can't think of it right now. Um,
okay.
that's why I didn't say, because I don't remember. It might be in the notes that you have somewhere. Um, I probably abbreviated. I can't think of what it is. So I don't want to tell you something that I don't think it is, but yeah, it might be like lymphadenopathy, maybe something like that. But I can't think of what it is. That's why I didn't say it. Um, okay. Sorry that I couldn't be more helpful with that question. I just don't remember what I wrote for that. Um, okay. But the next one is measles, or like I said, rubeola. Same thing, right? Natural disease. So you can get it naturally, or you could and get the immunity that way, or have the live vaccine. There's that prodromal period of 2 to 4 days. So like the beginning, initial parts, you're gonna really see fever and something that we call the 3 C's. So we're gonna have something called Corza, which is like runny nose, cough, and conjunctivitis. That's really going to tell you, which is itchy eyes. Those are your characteristic symptoms for rubeola or measles. That's going to separate it from the other diseases, right? They're going to have a fever, they're going to have these 3 C's. In addition to that, they're going to have photosensitivity and something called Koplik spots. Now, Koplik spots are these irregular red little spots in the mouth that also are bluish white tint. Um, and they're kind of almost going to look like little grains of white sand surrounded by like a ring. So it's almost look like a white dot with like a red circular ring around it in the mouth. Okay. Now, once again, these patients also present like in rubella with the red maculopapular that starts on the face and goes down to the trunk, right? So that can be confusing, but I'm going to say know these, right? Because this is what's going to separate this disease from rubella or German measles. So treatment, very similar, right? Antipyretics, but for these patients, you want to promote bed rest, adequate fluid intake, especially because the bed rest being that they have photosensitivity, so bright lights and things are not good for them. So we want to keep them in a dim, low lit room and keep them calm. We also want to put them on airborne precautions because measles, right, is an airborne illness. And we want to have cool mist communication to help with some of those symptoms. So, yeah, that's pretty much all that I have to share for that. So, I would know this is what separates it because they all pretty much have some sort of maculopapular rasp. But what is the difference between these? And that's what I'm hoping you're getting from this. And the last one is roseola or the sixth disease. So basically, what they have is a really sudden high fever that persists for 3 to 5 days. And it's non responsive to any sort of antipyretic. So you can give them acetaminophen every day for 5 days, and they're not going to resolve that fever. They're also gonna have a rash, but when the fever resolves, so once the fever actually goes away, they're gonna have this maculopapular rash that follows right after the fever is gone for 1 to 3 days. So that's what separates each, but they all have the same characteristically looking rash. It's just what happens, right? Like what sort of would let you know this is measles versus this is roseola versus this is rubella. Same sort of thing, right? There's fever, so we want to control the fever, typically alternating between like acetaminophen and NSAIDs like ibuprofen. good hydration, because we said anytime there's a fever, you want to make sure you give good fluids because we want to prevent any sort of dehydration. And we need to monitor for these patients, which is the big concern, is febrile seizures, right? Because they're having a fever that's lasting maybe 5 days without any treatment, right? And we know that our body can only handle so much of a higher temperature. If it gets too high, you could start to have seizures. Okay, so our goals is to really make sure we can control that fever, and give them good fluid intake, because fluid intake helps with lowering and reducing the fever, and monitoring for febrile seizures. So there's a few different things you can see here that separates them, but I hope that does help. Now, another viral illness is mumps or parotitis. Now, same sort of thing where immunity can come from natural disease or live. If you get the live vaccine, you could have immunity to it, or if you get exposed to it. Oh, one more thing I forgot to add is that for roseola, it's caused by the herpes virus, and there's no immunity to it. So all the other ones, you could either get it naturally and become immune or get the vaccine. This one has no vaccine, and you can only get it if you get exposed to a herpes virus. So just I want to put that out there because I didn't mention that before. But back to mumps. So mumps could also be called parotitis. So it has mild systemic symptoms like fever, headache, malaise, something that someone would typically present with, especially with like an upper infection. But parotitis, they're gonna have specifically inflammation and swelling of the parotoid glands that's going to last 1 to 3 days, and it's going to have a lot of pain and tenderness. So with these patients, they have a lot of pain, right? They have these swollen facial glands, right? They're having really swollen parotoid glands. Nutrition, just like in the hand, foot, and mouth disease, is the priority because of the fact that it might be very uncomfortable to eat. So, soft, bland foods, no citrus juices or sodas, and an ice collar around the neck is very good, and can be very soothing. A complication, especially for males, is something called ortitis, which is an inflammation of the testes, and it can cause testicular atrophy and lead to sterility. So they might not be able to have children if they get exposed to mumps, and especially our male patients. So I just wanted to point that out because I think she did ask a question about that, and I wanted to point that out for you. Okay, so that's all I have for mumps. Is there any questions about any of that?
Yes. I don't understand why, if all of these the rubella, rubiola, and ruseola, if they are all like some kind of rash, why do they all have like different precautions? Because I can't get my head past, like, after I move forward and I study something else, I have to come back and remember what precaution what is. Like, if they are both rash while one of them is droplet, one of them is airborne, it doesn't make no sense to me.
I think it's because even though it's the same looking rash, like they're both maculopapular, specifically when someone who has measles, these when they let's just say when they burst, right, or they begin to like heal, that fluid that comes out actually lingers in the air. That's why they call it airborne, because they have something called nuclei droplets. So like they have these little um particles that last in the air for longer periods of time. So, for example, someone on droplet precautions, if they sneeze, right, as long as they don't sneeze on you, it's not in the air still. But someone who has an airborne disease, that nuclei droplet is basically just sitting in the air for a long period of time. So, someone who has measles has this rash, but also has this fever, and anything that comes out of them almost lasts in the air, like it sits around. So that's why for someone who has measles, right, they're on airborne precautions, whereas someone who has rubella isn't, because of the fact that that's not what happens when while the rash is occurring. It's not letting out this particle nuclei into the air. That's why. For the same reason, right, varicella is considered airborne. but could also be considered contact. And that's because the rash is contagious, right, to touch. But when the rash starts to go away or it starts to burst, there's like particles that sit in the air. I hope that helps, or I hope it didn't make you more confused.
That helped. Thank you.
That's pretty much my basic level knowledge when it comes to difference between like droplets and airborne, is that airborne has this like nuclei that last in the air. Same thing with like TB, right? When they spit or cough, their particles stay in the air. Like that's why you have to wear an N95 because they don't go away right away. They linger. So the air is basically contaminated in a way. It's a very interesting thing. Um, okay. So the next thing is our parasitic infections, and one of them being head lice or pediculosis capitis. I'm going to say it like that. So that's what we call lice, right? It's a parasitic infection of the scalp, and you typically see this in school age children, and it's contact, right? So you get head to head contact, like such as sharing a brush, right? It could also be due to fomites. Manifestations include really extreme itching, and you can see these like visible little nits that are attached firmly to the hair. Like you see those little, almost like little balls on the hair, like little crusty balls. Yeah, that they're getting stuck to their hair. The diagnosis is when they use a comb to move around the hair, they see these little nits in the hair. But how do we treat it, right? Now there's this is really important. She asked a lot about this. So we want to kill the active lice and remove these little nits, right? And we also want to prevent the spread and reoccurrence because it's very contagious. So you need to manually remove them for children under the age of 2 over a 2-week period. So you have to actually, if they're under the age of 2 and they have lice, you have to actually manually remove every single one. And there's no prescriptions. Um, but the only prescription you can give, like there's not like a lot of different things you can give for a child under 2 except Lindan, or it's called Quell, but it can be neurotoxic. That's the only thing we can give to them, but we actually have to manually remove the nits from a child under 2. If they're greater than 2. If they're under 2, we can give them an over the counter no, not an over the counter. We cannot give children under the age of 2 this over-the-counter pediculicide, which is basically called permethrin 1%, or lidocaine. Basically, all of those would not be good for someone who's under the age of 2. But when you give them this sort of like cream, it has this residual effect for 10 days. So you have to be careful with that. And it kills the lice and the eggs with the first application. So once it goes on, it's really gonna get rid of it. That's why you can't give it to children who are under the age of 2 because it can be really neurotoxic to them. But over the age of 2, yeah, you can. Um, and basically, you want to retreat it again in 7 to 9 days. That's because it doesn't go away right away. And in order to kill it, you kind of have to redo it again. And for environmental control, you have to treat everybody who's in close contact with this. So you need to wash everything really thoroughly in hot water. Any combs, hairbrushes, clothing, bed sheets, everything that you can wash needs to be washed. Toys, personal items, things that can be touched but are not like used, on the body, things like that need to be in a plastic bag for 2 weeks, okay? Um, and just to clarify, you like I said, manually remove them for under the age of 2, and you're not going to give any sorts of medications for them. Any child over the age of 2, you're going to give them the medications like permethrin 1%, or Lindane, things like that. Okay. The next thing is scabies. Now, scabies is an infestation of these like little scaby mites that get under the skin, and you get it when you're in close contact with someone else, and it's usually people who have poor hygiene have this. Um, so usually what happens is that there's this little female mite that gets onto the skin and starts laying eggs, and it leaves a rash. So every rash that you see on a person who has scabies is a trail of the eggs from that little mite. and they have really bad itching, especially at night. It's even worse at night. And they also have this erythematous papular rash with excoriations. And if just for excoriations, that basically means that it's like um, you sort of pick at the skin. So what happens is that when they have this really itchy rash, they start picking at it, and the skin starts to kind of come up, and they get these sort of broken skin that can basically cause swelling and redness. Um, and that's the result of them scratching at it so much. So also you can use permethrin cream, 5%, but you leave it overnight for 8 hours, okay? You leave it overnight, you don't wash, you don't do anything. Once you put it on, you let it air dry, you keep it overnight, and then you wash it off in the morning. So you sleep with it basically. And the itching persists for 2 weeks, not for 2 weeks, for weeks after treatment, okay? So even though they're getting this treatment that's gonna help them, they're still gonna have itching. So there's going to be two applications, and they're going to be 1 week apart from each other. So the first one, you give it overnight, right? They leave it on for 8 hours, wash it in the morning, let them know, hey, you're still going to have itching even after this treatment. And we do another one a week apart. And when you give that second one, same sort of thing, right? Overnight, 8 hours, don't shower, don't wash it all, things like that. Okay. For nursing management, same sort of thing, treating all the household members and making sure that we have precautions for safety, such as washing all the clothes, the bedding, the linens, preventing any sort of secondary infections. Because remember, they're picking at the skin, excoriations, they're picking at it, they're making it red. So we need to make sure we prevent that. We want to keep the nails short and cut short because once again, they're going to be scratching at themselves. So if they're long, they're more likely to cause more damage. Make sure they have no scratching. And if we need to, especially on our little kids, put mitts on them if they really can't stop scratching at it. Okay. So, pinworms is another common infection. It's usually from the fecal oral route. Okay. This is due to worms, right? And the manifestations are going to be a lot of anal itching, especially at night. Um, and for adult worms, right? Like you might see them in that like perineal area. That's where you're going to kind of see these like worms. And the way you're going to figure it out is you're going to do a tape test. So you're going to basically take a piece of tape, put it over the opening of the rectum overnight. The next morning, pull it off, and you'll actually see little worms on the tape. That's how you know the child has pinworms. So for treatment, you're going to give mebendazole, which is a single dose that you repeat in 2 weeks. Um, and for nursing care, it's showering in the morning, washing the clothes in bed, right? No sandboxes, because sandboxes have a lot of worms in them. And the way to prevent the spread of it is good hand hygiene. 'Cause remember, fecal oral route. So we have to be careful with that. Another type of infections that we have are zoonotic infections, which these are vector-borne, such as Lyme disease, where you get it from the bite of an infected deer tick. So the tick gets on a deer, catches something, goes on you. So incidence is usually between ages 5 to 14 years of age, so our school-age children. The diagnosis is this right over here, you see on the right, this bullseye rash. And she does put pictures. So whatever pictures you have and you're seeing that are in your slides are going to be the pictures that she puts. She could literally just put, what does this patient have? And they have, I think she even did that for Lyme disease. She literally put the picture of that and said, what do you think the patient has based on this picture? So for antibiotics, we give if they're over if they're over the age of 8, we give doxycycline. If they're under the age of 8, we give amoxicillin. Okay. So know that because I think she asked about that. Nursing assessments include, remember, we're looking for any sort of history of a tick bite, especially if they were said they were up in the mountains for a weekend. Assess for characteristics of a ring-like rash. Assess for fever, malaise, mild neck stiffness, headache, joint pain, or arthralgia. Antibiotic therapy potentially, especially if let's just say we want to prevent any secondary infections. And remember, we don't know what the ticks have, so we're giving them the antibiotics to treat this zoonotic treatment. So doxycycline, remember, greater than 8, less than 8 amoxicillin. Prevention is key. So we want to make sure that we know if they've been in any sort of areas where they're exposed to a lot of deers, right? Make sure they wear long sleeves and cover themselves when they're in those areas. Light colored clothing so that if you see a tick, you could try to pull it off. And always check the body, right? Even for yourself, even if you're not a child, you should be wearing long sleeve pants and light colored clothing in like those type of areas, because Lyme disease can actually have long lasting effects if not treated properly and not treated right away. I know because I had a cousin who had Lyme disease, and it could be very painful, very paralyzing at times. So definitely you don't want to be exposed to that um, if you don't need to. Okay. You guys got to chapter 38 on neurological disorders?
Yeah.
Okay. So, increased intracranial pressure. Now, you probably remember some of this from med-surg, but it represents itself a little different in children. Now, as we know, increased intracranial pressure is this pressure that's exerted by the blood, brain, and cerebrospinal fluid, anything that's sort of putting this pressure onto the brain, right? So it could be an increase in blood, right? Increase in cerebrospinal fluid, any sort of fluid or mass that's occupying the space, right? Um, the changes that are going to occur is that there's going to be alterations in the brain, right? There's going to be problems with the cerebrospinal fluid and cerebral blood flow. So, how could it be caused? It can be caused by a few different things, right? A tumor, trauma. They have an infection like bacterial meningitis, or if they have overproduction of cerebrospinal fluid like hydrocephalus, or they have a malabsorption of cerebrospinal fluid. Now, you do need to know how they present in different age groups. So in infants up to the age of 18 months, right, when that fontanelle closes, so in between infant and 18 months, they're going to represent with poor feedings, vomiting, high-pitched cry, irritability, lethargy, and an enlarged head. So this is going to present itself as um, an increased head circumference. So if we're going to do any sort of procedure, we want to assess pre-op and post-op, right? They're going to have separated sutures, this bulging and an enlarged fontanelle, because remember the fontanelle isn't closed yet, and they're going to have sun-setting eyes, okay? And they're going to have dilated scalp veins. Whereas for the older children, after those fontanelles and those sutures close, right? They're going to have an unrelenting headache. They're going to have visual disturbances, such as having diplopia or double vision, flashing of lights, and they might see floaters, which are like little like dots kind of flying around. Um, they have in their pupil evaluation, what we might see is that when the pupils are dilated with a sluggish or even absent constriction in response to light. So when they're doing perla, it's not really doing so good, or they could be fixed and dilated, and that's an ominous sign, meaning they have neuro impairment. Okay, if the eyes are not doing anything, right? That's very bad. We want some sort of movement, but if there's nothing, we were thinking a neuro issue, right? They could have behavioral issues, changes of consciousness, nausea and vomiting, abnormal posturing. So if you remember decerebrate and decorticate positioning, both under 18 months of age and older than 18 months of age have sun-setting eyes. So that's not something that's different in either of them. But for these older adults, they could have seizures. They'll have vital sign changes. So specifically, they'll have an elevated temperature and elevated blood pressure and bradycardia. And we want to use the Glasgow Coma scale on these patients to assess the eye, verbal, and motor responses. So just in case you don't remember, decerebrate and decorticate are different positions that would be ominous of, neurological damage. So I always remember decerebrate as the C in between the not the C, the E between the C and the R for extension. So both the hand is extended, right? The feet are always flexed. But for decorticate, I always thought between the O between the C and the R as on. So like the hands are on them. So the feet are flexed and their hands are flexed towards their chest. That's just something that always helped me remembering the different positions. I don't remember specifically if she asked about those, but just in case. Um, for management, once again, we need to figure out what the cause of it, right? Is it a tumor? Is it a head trauma? Is it bacterial meningitis, right? What do we do? But our priority is airway, okay? So that is our goal. So if there's a question is, what is your priority? It's going to be airway. The goal though is to also preserve cerebral metabolic functioning. Um, Medications include anti-seizure medications, corticosteroids to reduce any sort of inflammation, antibiotics, sedatives, maybe, but no barbiturates. And we want to give mannitol. We know that mannitol is an osmotic diuretic that helps reduce cerebral swelling and any sort of fluid that builds up over there. So we know we're going to give them mannitol. Nursing considerations is having the head of the bed elevated 30 to 40 degrees, monitoring your vital signs, level of consciousness, seizure precautions. I kept it on the right. It's box 38.1 in your textbook, but it still applies, right? Padding at the side rails, nothing in the throat. Make sure you turn them to the side, right? Have oxygen and suction at the bedside. Um, Nothing by mouth, especially if they have decreased level of consciousness. IV fluids, looking for signs of infection, having good bladder and bowel elimination, and have family support. Now remember, because they have intracranial pressure, you can't move the head too much, right? Because then that's going to increase the pressure more. That's why I want to keep the head of the bed at 30 to 45 degrees. Now, another neural tube defect that we have, well, that wasn't a neural tube defect, but a neural tube defect that we have is hydrocephalus. Now, we said that could be the reason why someone has ICP, right? But this is when we have excessive amounts of cerebrospinal fluid. These ventricles in the head, they become really dilated. The brain is compressed against the skull. It could be congenital, like they're born with it, or it's acquired through something. It's usually associated with spina bifida. So the diagnosis is just, the prognosis, sorry, is dependent on the cause and the incidence of the injury. Now, the manifestations also differ by age. So, infant, they're going to have an increased head circumference, a disproportionately large head to the face. They're going to have wide space sutures and a bulging anterior fontanelle. Remember, this is for a baby who is less than 18 months of age who hasn't had that anterior fontanelle closed yet. So that's why, they're going to have the bulging anterior fontanelles. Someone who is 18 plus, right, older than 18 months of age, is going to have the sutures and fontanelles closed. So we're looking for signs of increased intracranial pressure. So now that you know, wait a second, hydrocephalus presents like this in infants, and I know that in older than 18 months, they have signs of increased intracranial pressure, I need to go back and reread my manifestations of that to know what I should be looking for with someone with hydrocephalus, which makes sense because, as we said, hydrocephalus can be a cause of increased intracranial pressure. So treatment, surgery usually, they can do something called a ventricular peritoneal shunt, which basically allows that cerebrospinal fluid to drain out from the head and go into the peritoneal cavity so you can kind of like poop it out, right? And basically, you're gonna have to actually change this shunt as they grow, right? So this is gonna be something that you're gonna have to continually kind of have replaced as they grow because the size of the ventricular peritoneal shunt is going to change as they grow, right? A baby or someone who's 18 months of age is gonna have a shunt that goes from the brain to the stomach is gonna look a lot different on someone who's now 7 years old and is not so tiny, right? Complications of the shunt include infection, malfunction. We might see things such as mechanical obstruction, thrombosis, or some sort of displacement. And the parents need to know signs and symptoms of increased intracranial pressure based on their age. So, preoperatively, we want to measure the head circumference, right? This is where I was saying before you have to measure the head pre-op and post-op. So, we want to look at the head, what it looks like before, and what it looks like after, right? We want to assess for indications of increased intracranial pressure, keep the head of the bed elevated 30 to 45 degrees. Vital signs, seizure precautions, intake and output, small frequent feedings, right? Their NPO. Um, until they're NPO, right? Because they're going to have to be NPO a certain amount of hours before the procedure, skin assessment, and frequent position changes so we can prevent any sort of ulcerations, right? But for postoperatively, we do not allow the child to lay on the same side of the shunt, okay? They must lie flat to prevent decompression, okay? They can lay on the opposite side of the shunt. So initially what we're going to do is this. We're going to put them on the opposite side of where the shunt was placed, and then gradually elevate the head over time to get them to flat, and also slowly raise the head of the bed over a certain amount of time within 2 days, because, like we said, increased intracranial pressure occurs, especially if you start moving them very quickly. That's going to affect um, the pressure in the brain. So we want to do it very, very slowly. By the second day postoperatively, the head of the bed should be at 30 to 45 degrees. So this is like a slow, gradual process, right? So you keep them on the opposite side of where the shunt is. You're slowly turning them to get them flat, and you're slowly raising the bed to 30 to 45 degrees. On the second day postoperatively, they'll be at that height. Once again, look for signs of the increase intracranial pressure, infection, looking at the surgical site, neuro status, vital signs, intake and output, nutrition and feeding, all the stuff that you typically would do for surgery, but especially you want to look for signs of increased intracranial pressure, right? Because that's what they're at risk for. Making sure that there's continuity of care. So they're going to continually have to assess the neurological function, and we have to tell the parents how to look for that. Remember shunt revisions because it changes with growth. Developmental milestones. So let's just see if like they're having any sort of delays in those gross and fine motor movements as a child's supposed to experience, and look for any complications of increased intracranial pressure. And we have to avoid contact sports with these patients, but swimming is fine. Early interventions and family teaching. The next thing is meningitis. So meningitis is inflammation of the meninges of the brain, which could be either bacterial or viral. We said bacterial could cause increased intracranial pressure. So you keep thinking, right? If these are what can cause increased intracranial pressure, we need to watch out for signs and symptoms of that for all these patients, right? So, um, meningitis is usually a secondary response to some sort of primary infection that enters the bloodstream. So they had something else and it seeped in. Um, for infants and young children, so this is talking about once again less than 18 months of age, right? Around that time. We're talking about poor feedings, poor crying, or spasmodic muscle tone. They could have hypo or hyperthermia, maybe even hypoglycemia. They could have seizures and a bulging anterior fontanelle, right? Because we're talking about a young little baby, right? But for an older child, we're talking about indications of increased intracranial pressure, photophobia, so we need to have dim low lights, severe headache, neutral rigidity or neck stiffness. They can have Koenig sign and Brudzinski sign. So Koenig sign is pain with the extension of the leg, and Brzezinski sign is flexion of the head that causes pain, and there's flexion of the hips and the knees. There could also be a presence of this purpuric type rash, but that requires immediate medical attention. So basically, an older adult child or a child over 18 months of age presents with the signs and symptoms of meningitis of what you would see in an older adult, right? Um, Diagnosis includes elevated WBC, hypoglycemia, right? That could tell us that in the CBC, and a lumbar puncture. So the lumbar puncture, we'll get that culture and sensitivity. We'll see this white blood cell count greater than 100 per cubic millimeter. Cloudy to purulent color of cerebrospinal fluid. That's going to let us know, hey, they have meningitis, because cerebrospinal fluid is supposed to be clear. We know they'll have lower sugar levels, so less than 45. I would know that. And the protein will also be increased in that cerebrospinal fluid because it's trying to fight bacteria. So all of that would be abnormal. Treatment, antibiotic therapy, especially if it's caused by bacterial meningitis. Um, so 7 to 10 days. We always assume that the patient with meningitis, it's caused by bacteria. So we're going to give a penicillin type antibiotic, dexamethasone to help decrease any sort of inflammation. Preventative would be the meningococcal conjugate vaccine, and also the Hemiphilis influenza B vaccine would be preventative. Isolation, once again, these are droplet precaution patients. Um, so, and they need to be put on isolation until after 24 hours of initiation of the antibiotics. And because, they could spit things and things, you want to have a gown, gloves, and mask. Other things include making sure we assess that respiratory status, as that's always priority, right? oxygen as needed, isolation for a minimum of 24 hours with the antibiotics, making sure we look for signs of an increase in intracranial pressure. And if they have that, to minimize it, we already talked about this, but avoiding extending, flexing, or rotating the head. The head needs to stay neutral because we talked about the importance of keeping like the head midline so you don't increase that pressure. Making sure you have a dark, quiet room. Remember, they have photophobia. Um, Nothing by mouth with decreased LOC. Once again, that's just a precaution to prevent aspiration, right? And make sure that we have the bed in a really low position and have seizure precautions in place. The next thing is Ray's syndrome. Now, Ray's syndrome is caused by aspirin, ingestion of aspirin. This is why we don't give aspirin. Now, the thing about Ray's syndrome is you usually have some sort of viral infection prior, like maybe influenza, maybe varicella, maybe something else, and you take aspirin. You give your child aspirin. Now, the problem with that is that if you give aspirin, they can develop Ray's syndrome, which is this acute life-threatening encephalopathy, um, which is basically the head starts to really swell, right? And then they have these fatty deposits in the liver and the kidneys, and it's very life-threatening because it has a very rapid onset. They're going to have uncontrolled vomiting with or without a fever. The child's going to suddenly become lethargic, and the vomiting is going to be followed by a rapid loss of level of consciousness. They're going to have pupil dilation, then they'll go to a coma, then they'll go into decorticate or decerebrate positioning, and death can occur 2 to 3 days after onset of symptoms. That's how scary it is to give aspirin to a child because of this particular disease. Now, because we said that they can have fatty deposits in the liver, we need to look at liver enzymes such as ALT and AST. We expect them to be elevated if they have this. They'll have an elevated serum ammonium level. We want to look at serum electrolytes. They could have hypoglycemia. CBC will show that they have low hemoglobin, low hematocrit, low platelet, and the coagulation times may be prolonged. We also want to have a cerebrospinal fluid analysis if it's caused by like viral meningitis via a lumbar puncture. Now, once again, right, this is life-threatening. So oxygen, mechanical ventilation becomes a priority, right? Keep O2 stat greater than 95, hydration, keep the head of the bed 30 to 45 degrees, neutral position. They could have increased intracranial pressure, seizure precautions, monitor pain and response to stimuli, because I said it can get progressively worse. So slowly they become more lethargic, then they're in a comatose state, now they're in the corticate and decerebrate positioning, um, and things like that. For medications, I came up with this because this little I called it Cabo because at the time I was going to Cabo in Mexico, so it was the only thing that would actually help me remember it. But I use Cabo, so you would give them corticosteroids is the C, the A is for anticonvulsants, the B is for barbiturates to induce coma, and O for osmotic diuretics. This is the only time where you're going to give barbiturates, otherwise we don't give them. We also want to do INOs, daily weights, neuro assessment, right? For our diuretic, it follows the same rules as another one, right? Watch out for dehydration, blood pressure, because this is a diuretic, so they could be going a lot. They're at risk for dehydration, things like that. Okay. Now, I'm not going to go over GU, but is there any questions about this? Okay. So, yes, I have the short little video of 7 minutes that I forgot about, but if you need to review this, go back to that. Okay, so the next thing is musculoskeletal and neuromuscular disorders. So we have a few different things. Cast are really important. They come up a lot on practice exams that I see. Casts are very commonly asked because kids are very prone to hurting themselves. But the point of the cast is to immobilize a bone. And we want to correct the deformities and reduce the fracture, and we want to make sure that we can realign the bone. So a priority is always neurovascular assessment prior to application and after application of the cast. Now that includes the 6 Ps, right? Or sometimes they say 5 Ps, but it's always six because there's always a sixth one. It's pain, pallor, paresthesia, paralysis, polythermia, which means coolness of the extremities, and paralysis. No, I think I said paralysis or pulse. If I didn't say pulse, then pulses. But yeah, pain, pulse, pallor, polythermia, paresthesia, and paralysis. Those are what we're looking for. In addition to that, that's basically what I said, right? Sensation, numbness or tingling or paresthesia, skin temperature, cool to touch or polythermia. Pallor skin would be pale-ish coloring, maybe even blue. Capillary refill should be less than 2 seconds, but if they're having a neurovascular problem, it would be prolonged. Pulses, we should see pulses should be good, but they could be decreased or absent. That would be problematic, right? Paralysis, decreased movement, and edema. So, once again, we need to look for our neurovascular assessment. Now, for the different types of cast, there's a plaster cast or a plaster of Paris, which is heavy. It's not water resistant and it takes 72 hours to dry. So with the plaster cast, you actually have to handle it with your palm of your hands. You can't pick it up with your fingertip. So you can't do that. So it has to be handled with the palm of your hands. Also, once the cast is dry, you have to use tape to put it on the underside of the cast to decrease skin irritation. Now, the fiberglass is actually really light and it's water resistant and it dries within 20 minutes. So that is a little bit better, especially, for younger children who might be prone to touching things and things like that. Once again, we want to have a pain assessment. We want to check for any sort of skin impairment because remember they have a cast that could irritate their skin. We want to protect from moisture and you want to elevate the cast above the heart, regardless of the type of cast, for the first 24 to 48 hours to reduce edema and to promote blood flow to the heart, right? Okay. Now we have neural tube defects. Now, this is something that's really important that comes up a lot too. So we said to prevent neural tube defects, we give a mom folic acid. We tell them to take folic acid, right? Sometimes families don't always do that, and that can lead to problems in the spinal cord development. And this can be pretty scary. So we know that we tell women daily to take folic acid of 0.4 mg per day, and that's how we reduce this risk. However, sometimes things happen. Now, the degree of disability is determined by where the defect occurs along the spine, and spina bifida is any sort of neural tube disorder that affects the spine. And there's a few different ones, and you do have to know them. These are the pictures of them, but we're going to talk about all of them. So the first one is spina oculata, I'm going to say it like that, is basically the failure of that posterior vertebrae arch to fuse. And most often it's at that fifth lumbar or first sacral vertebrae. Okay, so it's very in that lower part of the spine, right? There's no herniation of the spinal cord or meninges, no protrusion of the cords. There's no sensory or motor defects. It might not even be visible, but how would you know? They have a dimple on their back. If they have a dimple on their back, that's the diagnosis, and it can be seen on x-ray. You need to know these because I think she asked like select a lot of eyes for the differences of these. The meningitis is, you see, it's this third picture here where this little sac protrudes from the spine. There's a sac-like cyst with meninges filled with cerebrospinal fluid. There's no herniation of the spinal cord into the sac, and there's minor or no associated neurological defects, okay? So these two are very similar, the spinal ocular and meningochial, let's say it like that. But the meningochial has that sac cyst filled with cerebrospinal fluid, right? And it doesn't have a dimple on the back. For the myelinomeningeal, it's this bad guy over here all the way at the end. And the reason I say it like that is because that one is the most scary. It's a sac-like cyst with the meninges that has a cerebrospinal fluid, right? And basically it only affects what's below the cyst. And that's because this is having spinal roots and nerves in addition to having cerebrospinal fluid building up in the space. So you see the reason that the meningeal doesn't produce any sort of motor or sensory defects is because it's not having the nerves compressed or filled up in there, whereas the myelinomeningeal has all these spinal root nerves inside of that fluid space. So now they're having problems, anything below that like fifth, lumbar, first sacral space, right? So they can have complete or partial paralysis below that area. They're increased for infection such as meningitis. They're also at risk for hypoxia and hemorrhage. And it's very closely associated with hydrocephaly. And we said hydrocephaly is an overproduction, right, of cerebrospinal fluid. So how do we diagnose this? Well, they have a quad screen, the alpha fetoprotein. We could do a prenatal ultrasound, or you could see it at delivery. Like it'll literally be there. For therapeutic management, we have to do a prenatal microsurgical closure. We don't do that. The surgeon does that. But that's something that we need to think about that this patient will need. That the newborns, they'll have a surgical closure to decrease those risks, like of infection, morbidity, and even mortality. The sooner we do this, the better. The most concern, though, with this whole procedure is infection. And there's going to have to be lifelong management of neurological, orthopedic, and urinary bowel problems. Because remember, we're trying to remove this sac, and when they do, there could be a risk of damaging some of those nerves that are sitting inside of that sac. So now they might have problems going to the bathroom for the rest of their life, maybe problems moving. So they're going to have lifelong management of those things. So for pre-op considerations, always your ABCs, airway, breathing, circulation. We need to protect the sac and maintain its integrity to prevent infection. That is your priority, right? So of course you need to think about airway if they have an airway problem, but the main thing of not showing that in the question is that we need to protect the sac and maintain integrity to prevent infection. That's our main priority. So what we do is we put the patient on a prone or side lying position because they cannot lay on their back. Imagine having like a big ball sticking out of your back. They cannot lay on that. So they either need to be on their stomach or on the side. They cannot lay on their back. They need to have a moist, sterile saline dressing prior to the surgery covering it. And you need to avoid any sort of contamination with urine and species on that. Remember, we said our greatest concern is infection. Now, here's another thing that you should know. When they have it, when babies have that myelinomeningeal, when they have this thing over here, they're at risk for latex allergies. For some reason, when they have that, they also have latex allergies. So you need to have latex precautions. So we don't want to use latex gloves with these patients. We want to prevent and assess for infections. Look for things like hypothermia, hypoglycemia, respiratory distress, that little triangle we spoke about a long time ago. Because if you have respiratory distress or you have hypothermia, you're at risk for hypoglycemia and respiratory distress and vice versa. We want to assess the sac for leakage, measure the head circumference every 12 hours, and leg movement neurologically. That's what we want to look for as well. Post-operatively, priority becomes respiratory. So before, our most important thing is protecting the sac and maintaining the integrity. After, our priority becomes respiratory. Yes, we want to do vitals. We want to monitor for infection, those three things that we spoke about: fluid status, pain, skin integrity, head circumference, watching out for increased intracranial pressure. And remember, they're at risk for hydrocephaly. Most children will have a neurogenic bladder and neurogenic bowels, so they might not be able to, they might just go to the bathroom, so they may never actually have full control over their bowels again. So that's something to consider and teach the patients, families. Hey. Now the next thing is congenital clubfoot, or what we call talipes equinovarus, which is basically this congenital dysplasia of tissues, such as the bones, muscles, ligaments, and nerves, even the blood supply below the knee. It almost looks like a golf club. So how would you diagnose this? Well, you would do a prenatal ultrasound or even at the clinical examination. The management is to reduce or eliminate all components of deformity that result in a functional, structural, mobile, and pain-free foot. So our thing when they have a priority or the initial treatment is the casting method. So you basically have to have weekly gentle stretching and manipulation of the misaligned bones, which they do that with the cast. And the casts are changed every 1 to 2 weeks, and that's because they're growing, right? And we do passive range of motion. when the casts are off, and that's usually done by the parents. They may use these Dennis Brown splints, and surgery if the casting cannot remove it. So remember, think of congenital clubfooting, think cast. I need to do cast, and they're changed every 1 to 2 weeks. So cast care, once most important, remember weekly or bi-weekly cast changing, neurovascular checks, monitor for swelling, arrhythmia, elevate the legs, right, for a minimum of 24 hours above the heart. Patient education, and specifically for the parents, has to do with the casting, like how to do it, how to keep the cast clean using a sponge bath, and passive range of motion when the casts are off. There's also another musculoskeletal problem, which is called developmental dysplasia of the hip. And basically, that's when the head of the femur is improperly seated at the acetabulum of the pelvis. So basically, just know that for this, our first line treatment, especially for someone who is under the age of 6 months, becomes this Pavlik harness. And that's to maintain the flexion, abduction, and external rotation, right? Because we need to maintain the hip and joint movement, and we want to make sure these the hip aligns itself normally, right, for a growing child. After 6 months, they'll do a hip spica cast, and they could also do closed or open reduction or traction if they're over the age of 6 months of age. But anything under than 6 months, the Pavlik harness. Now, how would we know if someone has dysplasia of the hip? Well, they're going to have something called an Alice sign, which is unequal knee height, right? They're going to have asymmetry of the gluteal folds. They're going to have the ortolani or barbell sound, which is like the hip sort of clicks on examination. And they have gait abnormalities. So they sort of walk with a limp, sorry, a limp. So they don't really walk properly. And that's because they don't have, right, the equal height in the knees and all these other things. And the earlier diagnosed, the better. So if they're getting the Pavlik harness, right, for under the age of 6 months, we want to make sure we teach the patients how to put the patient's family, how to put it on and off, and they cannot adjust the straps. The straps of the Pavlik harness cannot change, okay? It needs to be worn constantly. It should be equal and symmetrical leg extension. There should be good skin assessment, right? Because it could be rubbing on the skin. There should always be clothes worn underneath the harness and things like that. If they're greater than 6 months of age and they have the spica cast or a full body cast, we need to monitor neurovascular status. We need to support the extremities. We want to manage elimination, and because remember, they're going to have a full body cast, so they're going to have a hard time going to the bathroom and peeing, which could also affect their skin and their skin integrity. So we want to watch out for all of that, and environmental stimulation, right? Imagine being in a full body cast and you can't really do anything. That could be not so fun. So we want to keep them still stimulated. The next thing is muscular dystrophy. Now, this is a group of disorders characterized by progressive degeneration of skeletal muscles. Duchenne, I'm gonna say it like that. Muscular dystrophy is the most common. It's usually only seen in males, and it's a sex-linked recessive trait, and it's usually diagnosed before the age of 6. So here's the thing. These children are going to typically present with meeting their developmental milestones in early age, but they're going to be late to learning how to walk. So they're going to do, at 5 months, roll over, head up, whatever. They're going to start doing all that. But when they're supposed to be walking, they're going to be late to learn how to walk. Then everything starts to decline around 3 years of age, and they're going to have progressive muscle weakness, wasting, and contracture, where they're noticing that their 3-year-old, let's just say, is starting to fall a lot, right? And they're not really able to ambulate, right? And by the ages of 7 and 12, they're not able to walk at all. They may or may not have a learning disability, but the way that we diagnose this is a muscle biopsy, which is going to tell us if they have fibrous degeneration and fatty deposits. So key things, like I said, preschoolers will start to fall down, right? When they're supposed to be walking, they just randomly fall, right? And they're going to have a waddling gait, and it's going to be difficult to climb stairs or running. And they're going to also eventually go into something what we call Gower sign. And Gower sign is when the child is down on the ground. They must use their arms and upper body to push themselves up. So they can't just get up naturally, okay? They need to use a lot of their body strength to get themselves up, like seen in this picture. So, nursing care includes corticosteroids to help maybe slow down the progression and reduce the inflammation, supportive care with physical therapy, low calorie, high protein. High protein helps build the muscle, high fiber, high liquid diet to prevent constipation. Primary goal is support respiratory status. Remember, this is progressive muscle weakness, which could potentially lead to muscle weakness in the lungs. Cerebral palsy is another type of musculoskeletal disorder. And it's characterized by a difficulty in controlling muscles. Now, it could be ranged from mild to severe. Cerebral palsy is not just like, oh, you have it, it's characterized the same way. Everybody could have it a little bit differently. It's a chronic non-progressive disorder of posture and movement, and it's due to this abnormal brain function. So this is non-progressive, and this one is progressive, okay? The muscular dystrophy is the progressive one. So how do you get cerebral palsy? What could be the cause of it? Prenatal is usually the cause. It could be perinatal or postnatal. So if you get bacterial meningitis, that could be a reason why you could develop cerebral palsy. Now, the manifestations once again vary. It depends on how mild or how severe it is, right? So they can have persistence of primitive reflexes. So we know that reflexes as a baby are some of them are supposed to go away at a certain time. Well, if they still have them, that's a problem. They have delayed gross motor development and they have lack of progress through developmental milestones. So we said with muscular dystrophy, they're going to show the developmental milestones, right? They're going to have the head lifting, turn when they're supposed to be, walk, like getting up to move. Like they're going to be doing all of those things in muscular dystrophy, but in cerebral palsy, no. The way we're going to start seeing this is when we see the child have failure to meet developmental norms, could be that first indication that this child has cerebral palsy. Now, management and goals, the priority becomes for this patient with cerebral palsy is to promote mobility, okay? And early recognition helps. So we want to do physical and occupational therapy, speech therapy, potentially orthopedic surgeries, medications, benzodiazepines, butylene toxin, and baclofen. And baclofen is going to help preventing that muscle weakness. The next thing is scoliosis, and scoliosis is the lateral curvature of the spine. So I've met a few people who've had scoliosis, but the highest risk is typically puberty when their growth rate is the fastest. And you're going to typically notice this through unequal shoulder and hip levels, the prominence of one scapula or the curved spinal cord, and asymmetry, right? So one shoulder will be higher than the other when they're standing. That's one way to see that. And you can kind of see the spine looking very curved instead of straight. And you could also see when you ask them doing this forward bending assessment. So when they bend over, like forward to, let's just say, pick up a pen that fell on the floor, one scapula is going to be higher than the other. So how do we treat this? Well, we have to prevent progression of the curve and decrease the impact on pulmonary and cardiac function. So we want to, continue to monitor this, have exercises to promote muscle tone. We could do bracing. So bracing, we could put on the child, its size to the child to help straighten out the back. We need to have a good skin assessment. And remember, we're talking about a teenager or a child going through puberty where now they're becoming more self-conscious of their body image, of their body appearance. So we need to promote a positive body image. They also could be surgery called the Harrington rod procedure. Now, this is where rods and screws and wires are placed next to the curvature to really help correct that spine and correct that position. So if we do this, we need to have good preoperative teaching, and then postoperatively, the priority becomes respiratory, okay? We give them the surgery, it's priority respiratory, and then all the other stuff, vital signs, neurovascular checks. But because we worked on the spine, right? They might have these rods and stuff all in the spine. We have to do the roll log technique if we want to move them. Pain management and also strict INOs. Think about anybody who has any sort of back procedure, always think roll log technique. The next thing is fractures, right? Kids break their bones, they hurt themselves a lot. A fracture is any break or disruption in the structure of bone when more stress is placed on the bone than it can absorb. Pediatric fractures in young children are seldom to complete breaks. Bones tend to bend and buckle because they're really flexible. So we don't really typically see the whole bone completely breaking apart in someone who is a child. But we're going to see which ones would be considered normal and which fractures would be considered abnormal. So I keep pictures in here. I like pictures too. The green stick fracture is an incomplete fracture, and she might show you diagrams, so I would know your diagrams, which would be, like I said, a little break into the bone. The buckle fracture is compression injury that pushes bones together from falling. So it's going to be due to some sort of like compression injury. So the buckle fracture you kind of see like in that wrist area where it's sort of squished and compressed. A bow fracture is bending. So the bottom picture is normal, a straight bone, but the top is the bone bends. Remember, because the bones in pediatric children are more flexible. There's also an epiphyseal fracture, which is basically the growth plate. Now, the epiphyseal plates control the growth factor, so that helps with children getting your height, right, so that you can grow. But this is very worrisome if they have any sort of fracture in that area, because that could prevent their growth and development. The last one is a spiral fracture where the bone completely breaks. You can kind of see comes off. When you see that, you need to suspect child abuse, okay? You need to suspect that, and you need to do a proper assessment. And that's one of the most important things out of all the fractures, okay? Is that that's not normal, and that usually is indicative of child abuse. Now, assessment, you're going to look at those 5 Ps. We already spoke about those. Diagnosis is going to be X-ray, CT, MRI, ultrasounds. Treatment, reduction and realignment, right? So maybe some sort of cast, things like that. We want to also immobilize. So you always, when you have like a bone fracture, you want to realign and immobilize, right? So you want to immobilize them through the cast or maybe splints or braces, depending on what the doctor orders. Any sort of application device that maintains alignment and, reduces mobility, things like that. We also have traction. Now, it really depends on the type of fracture, right? So the child is going to be immobile in this like machine thing. Something that you want to know is that you need to have priority, of course, respiratory assessment because they're lying flat in their back in traction. Other things include that neurovascular assessment, right? Sensation, skin temperature, skin color, capillary refill, pulse, edema, and movement, skin integrity, pain assessment, GI and GU because they can't get out of bed, nutrition, and mental status. Okay. Any questions about anything that we did so far? Okay. So like I said, any pictures that come with these disorders and the fractures, I would look at them. I remember she included a lot of pictures on the PEDs 2 quiz, or I know it's the final, but it's the same sort of thing. There's not going to be really more questions. It's still like the quiz. But we're going to talk about skin disorders, and we have one called impetigo, which is a bacterial infection that's highly contagious. It's a superficial skin infection. It usually begins due to some area of the broken skin, so maybe an insect bite, scabies, or even atopic dermatitis, and it has this localized inflammation. Now, where do you see this most often? Well, most often in infants and children, especially in these hot, humid summer months. They have poor hygiene practices, and they're in these crowded living conditions is going to increase the risk, as well as large gatherings. So think really hot places and lots of people, increase your risk for this. So it can be caused by either Staphylococcus aureus or group A beta hemolytic streptococci. It's going to look like this picture on the right, right? So it's going to be these inflamed erythematous macular lesions that are developed into these vesicles of papules, right? It's going to kind of almost blister. And it's going to have these exudate that dries and forms like a honey crust, like coating over it, right? And there's intense itchiness or pruritus because they pop and they crust. So it's going to look like this yellow little lesions. And then when it crusts over, it's going to look like that at the bottom picture, okay? So for treatment and diagnosis is on clinical presentation and culture. For treatment, we want good hand hygiene. Remember, we said a cause could be poor hand hygiene, right? You need to wash the lesions 3 times a day in warm soapy water, and don't use anything that has fragrance. You're going to use Burroughs solution to remove the crust and exudate. Don't try to scrape it off, just use the Burroughs solution. Antibiotic therapy is going to be topical for 7 to 10 days, and it's going to be applied 3 times a day. There's going to be muproprusin, which is a prescription called Bactroban, or bacitration, an over-the-counter, which could also be called Basagant. Those are your medications. I would know that, okay? Know your medications and know your treatment and what they look like, especially for these, okay? This one, I know she had a few questions on. But look at those pictures. I'm telling you, she's going to put a lot of pictures on there. There's also cellulitis, which is bacterial, which is basically painful arrhythmia and swelling. It's usually from a break in the skin, maybe a puncture, a scratch, something like that. Maybe if they have tonsillitis. Now, another place where I use Pew is for cellulitis. Just like osteomyelitis, there's Pew. So pain, edema, arrhythmia, and warmth. It typically looks like this picture on the right. So the clinical presentation is how you diagnose it. Look at the labs like the CBCs for elevated WBCs, blood, site cultures. The treatment, it could be treated at home depending on how bad it is. Joint or face or febrile illness. So if there's any sort of like inflammation and redness in the face and joint area, and they have a fever, they need to go to the hospital immediately. The antibiotics are going to be a 10-course with IV or oral cephalosporins. You can give acetaminophen or NSAIDs for pain and warm compresses every 4 hours. Remember, this is an inflammatory response. Now, another thing that we have is I don't think she really asked too much about the ringworm infections, but there is a few of them. So there's they're usually caused by these dermatophytes, which are like these group of fungi that invade that outer layer of the skin, hair, and nails. It's usually through direct contact, right? So these are like our contact patients, right? So there's Tinea capitis and Tinea corpus. So Tinea capitis, think of a baseball cap head. Tinea corpus, now corp usually means body, so body ringworm. So Tinea capitis is head ringworm. So they're basically going to have scalp scaling with or without alopecia or hair loss. The patches are going to be circular and itchy, so something like this, right? Circular. You want to use Burroughs solution, a topical antifungal medication, anything that ends in zole. So clotrimazole would be an antifungal. You could also give oral antifungals like gyrosaflun, which could be administered for at least 6 weeks. And you have to take it with milk or high-fat meal to increase absorption. I know she asked about this. For Tinea corpus, I'm just getting body ringworm. Think about ringworm, we're thinking about circles, just circles where. This is a superficial skin or nail. Basically the clinical manifestation would be round, red, scaly with pruritus, something like this, right? So topical antifungals for at least 4 weeks. So meconazole, clotrimazole, maintain clean and dry skin, and have pets examined. That's something that you really want to know for Tinea corpus because it could be from pets. So do you have any pets and have they been near any pets? Because that's where they could have got it from. Now, eczema or atopic dermatitis, these are inflammatory processes, right? They're chronic, they're superficial, inflammatory. You could typically see this more in the winter. It's usually allergy-mediated response to environmental stimuli. It could also be genetically, but it's usually allergic. The clinical manifestations include this red, edematous, itchy patches that crust and weep, sort of this like picture on the right. The itching usually intensifies and it's dry and roughness on the skin could be first indications. I don't know if anybody has ever had eczema, but it's just like really rough skin. And then eventually it becomes really red and then it could become patchy. And then eventually it could like almost like skin could start to break as a result too. Prevention, exclusive breastfeeding. and the diagnosis is just through how it presents. The treatment focuses on the symptoms and especially controlling the itching. So we want to avoid environmental triggers. Remember, we said it could be allergy related. Only cotton, clothes, no wool, oral and topical antihistamines like Benadryl and hydrocortisone. Monitor the diet for allergies. You can give a tepid and warm bath with mild soap with no fragrances to help with the itching and promote comfort. Moisturize the skin, especially you want to use emollients to apply when the skin is damp. So to put cream on to help with reducing that dryness, right? Because it's like this redness, it's very painful, and it could be very painful depending on how dry it gets, right? And it's inflamed skin, so that's why I want to do the anti-inflammatory ointments, do stuff to help with the itching, no bubble baths or oils or scented lotions. Keep the fingernails short and clean so you don't itch it, right? Or get it like infected. Cotton mitts over the hands of infants and young children, control scratching and prevent secondary infections. Antibiotics with a secondary infection, and avoid sunburn. It's going to make it worse. I would especially know for eczema and atopic dermatitis, the treatment, because I remember she asked like a selective that apply for this, so I would know that. I would know that. Okay. So the next chapter is 46 with hematologic disorders. So I would know what pediatric assent is, and this is how they understand what's going on developmentally. Now, assent is not consent. It's a verbal permission for treatment. So you want to consider the child's developmental capacity. We want to achieve age developmentally appropriate understanding of the illness, grant wishes when everything has been done, right? So if there's nothing more that you could do for the child, tell the child what he or she can expect with the testing and treatment, assess the child's understanding of the situation, note if there's like inappropriate pressure to assent to the testing or treatment, and seriously look at the child's expression for willingness of proposed plan. They should be, even though they don't have the consent as per se the parents, we really should be considering what the child wants to. Advanced disease, right? The decision to provide or withhold children is challenging ethically. Like, what do we do? But mature children, mature older children, or an adolescent not of 18-year-olds, as we said, grant their wishes when everything has been done that can be done and you can't do anything more. Now, palliative and hospice care are very different. Okay. So we want any dying children to die without pain, right? And we want to make sure that there's no continued suffering and we do as much good as we can. Though for younger children, older children, you take a little different techniques. So for younger children, we want to meet their needs and they want to be closer to their families. Infant and toddlers do not understand and they play off the anxiety of their parents. So we want to try to keep the parents calm so that the children can be calm. Preschoolers have magical thinking. So they're going to believe that they did something wrong, which is what caused their illness, as some sort of punishment. They're also going to view death as temporary. Older children require honest explanations of whatever is going on. The school-age child really understands the permanence of death. They understand that once they die, it's a permanent sequence, and they ask a lot of questions about the process. Now, adolescents act more like adults, so they also have that understanding and, may react differently. Now, the difference between palliative and hospice is palliative is comfort care. So it's providing the best quality of life possible at the end of life through like alleviating physical, psychological, emotional. The thing is that with both palliative care and hospice care believe in no pain, but palliative care, you still do treatments, okay? But in hospice care, you stop treatments. The main priority with hospice care is pain management. You're going to do comfort measures, but all treatments are withheld, okay? There's no treatments here like chemotherapies. This is just letting them go comfortably, like basic hygiene, comfort, things like that. Pain is the most important priority. For nursing care of the dying child, nurses are the advocates of the child and family, so we want to be compassionate, informative, and honest. All children have the right to die comfortably with palliation of symptoms. Pain management is central. Withdrawal of treatments, we got to think about who decides that, which is going to be the family, DNR, right? If they're DNR, whatever their status may be. Remember, our goal is prevention and alleviation of pain for the dying child. Okay, we want to have atraumatic care. We want to think about the diagnosis, think about where they should be dying, right? Where do they want to die? What to expect, how to explain it to the child depending on their developmental age, right? Do the parents want any mementos like a lock of hair, certain toys, things like that? Um, Organ donation, is that something the parents want to consider? And the nurses can go to the funeral too, right? The nurses, we can respond. We cared for these patients. We are able to also go to their funeral if we want to give our condolences, especially if we were very close to them and it would mean something to the family. Now, let's see, other things to include is that, this child is, let's just say, a cancer patient, right? And they have a lot of nausea and vomiting. We want to alleviate that in any way, shape, or form, right? So we want to assess how frequently they vomit, right? Making sure that they have small, frequent meals because the smaller amount it is, the less likely they'll vomit it. Avoid spicy foods that could upset the stomach. Um, Allow bubbles to dissipate from any carbonated beverages before they're ingested, and remove the cover of a meal tray before entering the room because the smell of food could kind of trigger nausea and vomiting. So you want to make sure that goes outside the room. Adequate nutrition, right? So determining the body weight, the height and norm, what's normal for the child, look at their food preferences, making sure that they get food they like, but food that's going to be adequate in calories and nutrients. Giving antiemetics as ordered so that they can retain the food they eat, always daily weights, offering the highest calorie meals to the child, making sure that there's whatever they do eat is increased, like puddings, high calorie food so that they can increase their weight gain, vitamins, minerals, and maybe TPN through central line if they need, if they can't take fluid orally or enterally. We want to restore a healthy mucosa, right? So we want to make sure we look for lesions, anything in the mouth, offer ice chips, um, especially while that child is NPO to maintain the hydration of the mouth. Only use a soft bristle toothbrush for dental care, avoiding any sort of excessive pressure, keeping the lips lubricated with petroleum jelly. Rinse the mouth with like salt solutions or mouthwash to keep the cavity clean and moist. Making sure that you have the child's swish and spit, which is a 1-to-1 Benadryl naloxone solution to decrease pain. Administer any antifungal solutions if they have any sort of oral candiditis. No spicy, acidic, very hot, or very cold foods. And administer pain medications as ordered. We want to prevent infections for these patients, right? Especially towards end of life and things like that. We want to make sure that we assess for any sorts of signs and symptoms of infection, fever, pain, cough, tachypnea, adventitious breath sounds, right? Are they having a temperature greater than 101.1? Have good hand hygiene, right? Because that always minimizes the risk of infectious organisms when we have good hand hygiene. Maintaining any sort of isolation precautions, avoiding any sort of rectal temperatures and examinations or intramuscular injections, anything that would be unnecessary, especially to a child who is neutropenic, to decrease any sort of introduction of microorganisms, educating families, and visitors that, you need to not go near them if you're sick, have good medical asepsis, good nutrition, things like that, making sure you administer vaccines, not live. Remember, no immunocompromised patients can have live vaccines. And make sure if they're home, they monitor that. Now, another thing is promoting body image. So we want to acknowledge any sort of feelings or changes over the body, letting them vent, encourage a child or teen if they want to choose wigs, hats, or scarves, right? Support the child or teen's choices in fashion style, right? Involve the child in decision making, encourage a child to spend time with peers who also have similar experiences, right? Like with hair or limb loss or whatever they're going through, because especially the teenagers and the older children are very peer influenced. So we want to make sure that if they can be around other people who feel the same way. Now, like I said, this is care and nursing analysis and health assessments. That can go a long way, not only for someone who could be at end of life, but also someone who has chemotherapy, right? Because chemotherapy, they're at risk for infections, they're at risk for hair loss, they're at risk for nausea and vomiting. So think about all of those interventions while you're also thinking about someone who could be a cancer patient, right? Now, there's a drug chart 46.1. I'm not gonna like really get into it, but I would highly, highly review iron supplements. You should know what they are for med surg, right? Like vitamin C, empty stomach, 1 hour before, 2 hours after meals. They could have dark stools. Liquid can stain the teeth, the iron supplement, so they should drink it through a straw. And constipation is very common with the iron supplements, so make sure they increase their fiber. So we have iron deficiency anemia. So we know this means anemia means lack of RBC production from some shape or way, right? And this is usually due from not getting enough iron, and this peaks between ages 12 to 24 months. And then female adolescents who have menstrual problems or poor nutrition. So just like anemia, they're going to have pallor, fatigue, conjunctiva, like pale, because remember, they're hypoxic. They have not enough RBCs. They're going to have lack of oxygenation. So things are going to be pale. They're going to be lethargic. They're going to feel fatigued and irritable. They're going to have brittle spoon-shaped fingernails, tachypnea, tachycardia, shortness of breath, and maybe even a heart murmur in severe cases. So what can it be caused by? Well, for infants, it's really caused by breastfed infants need additional iron intake around 4 months of age. So they should be around that time getting the recommended 4 to 6 milligrams daily. And iron fortified cereals should be one of the first foods that infants get at 6 months of age to prevent this. So there's methods that you could take to prevent it. If they're not doing these things, they can get it. Also, preterm babies or twins or triplets are at a higher risk. Toddlers who drink whole milk that doesn't contain iron, because whole milk doesn't have iron, that can increase their risk for iron deficiency anemia. Excessive milk with limited solid foods, and if they're like picky eaters, because toddlers are typically picky, that's another thing. For adolescents, the reason is that eat a lot of fast foods, some are vegetarians, and females due to menstruation or if they have bulimia, which is an eating disorder. So the pathophysiology, hemoglobin is iron poor. So what are we going to see on CBC? Low hemoglobin, less than 11.5, decreased RBCs. They're going to be microcytic and hypochromic. They're going to be pale looking and small, and they're going to have low serum ferritin iron levels. Management, they need to take their iron supplements and increase their iron intake. Now, depending on the age of the child, like we said, breast milk or formula, for the first 12 months of life, maybe the iron supplements to breastfed infants at that 4 months of age, if that's how old they are, or that iron fortified cereal at 6 months of age as the first food introduced. No cow's milk before 12 months of age. And if they have cow's milk, if they're, let's say, older toddler, like 14, 15 months and older, right, limit intake to cow's milk to 24 ounces a day. Offer solid foods before bottle and encourage food sources that are rich in iron. I'm not going to go over into iron supplements because I already went into that. But remember, vitamin C always increases the absorption of iron. So taking it with like orange juice. The next thing is sickle cell anemia. So sickle cell anemia is an inherited autosomal recessive genetic disease characterized by the production of sickle-shaped hemoglobin or what they call hemoglobin SS. So you typically see this in African Americans, Middle Easterns, Indian, Caribbean, Central, and South American descents. Clinical manifestations will do this heel stick for a baby to draw up the blood work to see what's going on. And symptoms will typically start appearing between 4 and 6 months of age when the baby actually is able to start producing their own hemoglobin. Now, remember, this is anemia, so they're going to have significant pallor, fatigue, and pale conjunctiva. Other manifestations are going to include severe pain from severe tissue hypoxia and ischemia, because these are like crescent-shaped cells. They're not the round, the way they're supposed to be. These are crescent-shaped. They have something called avascular necrosis of the hips and shoulders due to the poor blood flow and delayed growth in puberty. Now, definitive diagnosis, you could read that in one of the charts, the hemoglobin electrophoresis. Know that that's definitive diagnosis. Other ways that we could diagnose this is a sickle dex, which is a screening to detect the presence of hemoglobin SS, the CBCs, which we already talked about what that looks like for anemia, a newborn screening, as well as prenatal testing through the chorionic villus sampling or amniocentesis. Now, the goal is to prevent a vaso-occlusive episode, sickle cell crisis. So, we know that these patients have severe tissue hypoxia, right? And a vaso-occlusive episode further exacerbates that. So, if they have any fever, they need to go to the hospital immediately. They need to always have vaccinations and take penicillin prophylactically. Encourage fluid intake. They always need to be hydrated. Your priorities when it comes to sickle cell crisis is HOP, hydration, oxygenation, and pain. And hydration has to be first because we need the cells to be less sickle so that more circulating blood flow can get to the body. They need to avoid high altitudes, avoid temperatures that are too hot, too cold, avoid overexertion and stress, have a 24-hour access to any sort of physician. Contact the provider if you think your child is experiencing a pain crisis. Other things to look at is, are they having swollen joints, coughing, shortness of breath, chest pain, unusual headaches and weight loss, sudden visual disturbances. Males can have something called priapism. It's just when they have a painful erection that doesn't go down. And they can have other things, right? The child is pale and things like that. But remember, vaso-occlusive crisis, we're talking about lack of tissue perfusion. There's severe vasoconstriction, severe tissue hypoxia, severe necrosis, okay? They could also have something called dactylitis, which is symmetrical infarct of the bones of the hands and the feet that causes painful swelling of the soft tissue. So, other things is that the bilirubin and reticulocyte count are elevated. And that's because in sickle cell crisis, besides the RBCs being sickled or crest looking, it is also called hemolytic anemia. It's a type of hemolytic anemia, which means the red blood cells burst. And when red blood cells burst, they produce and release bilirubin. So someone who has a sickle cell crisis could also have jaundice because of too much bilirubin in the blood. Other things that happen with the RBC sickling, and I would know this, is that there's increased blood viscosity, that there's obstruction of blood flow, that cells pile up on each other, and there's tissue hypoxia that causes pain. I would know these three things. And it's this picture that she provided in there. Okay? So, other things, prevention of a crisis. Once again, no dehydration, no infections, right? We want to prevent infections, rest periods with activity, monitoring travel, no high altitudes, daily folic acid that helps make that. This is going to help produce RBCs, and they might need an RBC infusion. But regardless, the treatment and priority is HOP, HOP, hydration, oxygenation, pain. Even though I know they say oxygen first, you need to hydrate them because we need the cells to get bigger to carry more oxygen and reduce the sickling crisis. Complications include stroke. Remember, stroke can be caused by two things. There's two types of stroke, right? There's ischemic stroke and hemorrhagic stroke. Ischemic stroke is what they're at risk for, right? It gets so poor of tissue perfusion of blood vessels to the brain that they go and they have a stroke, okay? So that's why someone who has a CV as a result of a sickle cell crisis needs to have blood transfusions every 3 to 4 weeks. Another complication is priapism. They have a long erection of the penis and acute chest syndrome, which can be life-threatening because what happens is we said, right, the blood cells can do a few things, right? There's increased blood viscosity and there's obstruction of blood flow. So the red blood cells start piling up on each other. So what happens is blood cells start piling up in the lungs and it basically causes an occlusion. It causes obstruction. So now they're starting to have ischemia or ischemic pain in the pulmonary system. So they're having chest, back, and abdominal pain. They're having fever, cough, and tachypnea, and dyspnea, retractions, and decreased O2. Something that I made a cute little mnemonics. I like these things. I made SAP. So stroke, acute chest syndrome, and then priapism, SAP. I don't know. Just something that I thought helped me, and I'd share it with you guys. Any questions so far? Anything I've said? We're almost done. Almost done. The next thing is leukemia. Now, leukemia is a type of cancer, right? And what happens here is the bone marrow is suppressed. Now, bone marrow controls the production of blood cells, which means if bone marrow production is suppressed, that means white blood cells are suppressed. That means red blood cells are suppressed. That means platelets are suppressed. So they're going to have leukopenia or decreased WBC. They're going to have anemia or decreased RBCs. They're going to have thrombocytopenia and low platelets, okay? And I love this chart while studying. I think it was in the slides. It was great. You don't need to know really all the types of leukemia. I wouldn't know that. I would just maybe look over acute lymphoid leukemia, ALL, but I wouldn't look into anything else. So once again, if they're having anemia, right, as a result of suppressed bone marrow, they're going to have signs and symptoms of anemia. So weakness, pallor, fatigue. They're going to have depressed or decreased WBCs, right, which means they have immunosuppression, which means they have infection. We're looking for fever. They have decreased platelets, which means they have increased risk for bleeding and decreased clotting. So we want to look for petechiae, bruising, and purpura, okay? That's how you have to think of it. And everything that I just said right now are all the symptoms here. In addition, they can have bone or joint pain due to the hypoxia of the anemia. They can also have nausea and vomiting. They could have LAD. That's what it is. I was right. Lymphadenopathy. I don't know why. I said that before, but I didn't know. So back to that chart, LAD is lymphadenopathy. And neutropenia. So we already talked about neutropenia, anemia, and thrombocytopenia. But everything I just said, if you know and you could think of anemia, neutropenia, or leukopenia, and thrombocytopenia as what is happening with leukemia, then you know the manifestations because you know what anemia is, you know what a decreased WBC count can lead to, and you know what thrombocytopenia or what a low platelet count can do, right? So that's how I want you to think of it. So diagnosis is going to be a CBC with differential. It's going to show low hemoglobin, low hematocrit, low RBCs, decreased platelets. There could be elevated WBCs if they got exposed to an infection, right? It could also be decreased. So just think about that. It could be normal, but it's probably not going to be normal. It's going to be somewhere between elevated and decreased. Now, I'm not going to get into that. The prognosis is based on the initial WBC count and age. Management, chemotherapy. Now, chemotherapy, once again, is going to further increase the bone marrow suppression. So it's going to lead to greater degrees of neutropenia or leukopenia. Now, neutropenia just means a decreased neutrophil count, but that's a part of the leukopenia, right? Thrombocytopenia and anemia. So the symptoms that we already talked about before are just going to be even worse. Now the bone marrow suppression is going to occur 7 to 10 days after the chemo is administered. That's when we're going to see all these side effects. Now, I don't know where I came up with this, but I thought of BAM, and it was something that I thought about when I thought about common symptoms. So there's 2 B's, right? Bruising, bleeding. There's 2 A's, anorexia, alopecia. There's 2 M's, mucosal ulceration and malaise. And then there's 1 N for nausea and vomiting. But regardless, all of these symptoms are the same things that we are seeing as a result of having anemia, as a result of having leukopenia, and as a result of having thrombocytopenia, okay? And the mucosal ulceration is due to the fact that they're having the low WBC, so they're at risk for ulcerations in the mouth, as well as the anemia, right? The anemia is putting them at risk for hypoxia. They're hypoxic, they're having low perfusion, so less blood flow, especially in that mucosal area, puts you at risk for ulcerations. Now, these children need to be put on neutropenic or infection precautions. We need to tell the parents that they're going to notice more bruising and bleeding in their child, like petechiae, ecchymosis, nausea and vomiting. They could have ulcers in the mouth, in addition to, having the signs and symptoms for anemia, thrombocytopenia, and leukopenia. They're going to have alopecia or hair loss from the chemotherapy. Now, neutropenia means neutropenic precautions, right? Remember, these are our primary defense against bacterial infections, right? And without this or having decreased neutrophils, we have risk for opportunistic infections. So The fever may be the only thing that lets us know they have an infection. But what do? These patients who are having chemotherapy need to be on neutropenic precautions. So good hand hygiene, no sick people in the room, no fresh flowers, no fresh fruit or vegetables. If it says fresh, fruits and vegetables would be good if it doesn't say fresh or raw. Okay, don't have that for neutropenic because those are filled with microorganisms. You want to monitor the temperature and have reverse isolation. Remember, thrombocytopenia, we're going to have bleeding precautions for them, right? So if they're older child, right, electric razors, right, no contact sports, right, fall precautions, things like that. And tell them they'll see increased bruising, petechiae, purpura, and bleeding. Now the anemia, once again, increased pallor, fatigue, shortness of breath, and all the other symptoms we talked about, right? So nursing care has to do with the symptoms, the main ones, right? Anemia, thrombocytopenia, leukopenia. So I already talked about all of this, right? Also soft toothbrushes, right? As a part of those bleeding precautions. And for anemia, once again, we want to prevent injury. Same reason for the platelets to prevent bleeding. Rest, balance rest and activity for patients with chemotherapy because of the anemia, and give epigen, which is an RBC stimulant, is what we're going to give them. Additional things, once again, no live vaccines, they're immunocompromised. Assess mucous membranes for stomitis, which is those ulcerations, and their appetite. Remember, they might not want to eat as much with the appetite if they have stomitis. Strict intake and output and daily weights, vital signs, especially temperature, pain assessment, changes in LOC, things like that. Now, another cancer related topic is we have wilms tumor. Now, this is originated during fetal development, and it's a tumor on the kidney, and it usually occurs between ages 2 and 5. They're going to have this sort of bump at the waistband and flank. They could have hypertension and they could have hematuria. So we want to have a GU assessment with these patients who have a wilms tumor. Diagnosis will be a CT scan and an MRI. Interventions, because they're going to have this little bump at the waist, no palpation of the area. You want to assess blood pressure and urine results for hematuria and intake and output. So think GU assessment and no touching the bump. Treatments include surgical removal of the tumor, maybe a nephrectomy, or radiation and chemotherapy. The last thing is a retinoblastoma, which is cancer of the eye. Now, blastoma is like a type of tumor. It can metastasize, and it's most often found in children. Indications, the pupil, just know this. The pupil appears white when light is shined on it. And treatment just depends on the extent and size of metastasis, but just know that. Just know that for retinoblastoma. All right. Now, the last thing, which isn't much, is endocrine. And specifically, we're going to talk about diagnostic lab values, growth hormone deficiency, and that's pretty much it. So, the growth hormone. What I want to talk about with that is that growth hormone is released usually in response to insulin, arginine, clonidine, or glucagon. For indications, we want to evaluate and diagnose growth hormone deficiency. For nursing implications, this includes things like if we're giving them or having this procedure, if we're trying to test for growth hormone stimulation, we want to keep the child NPO, limit stress and physical activity for 30 minutes before, obtain blood samples at specific times, monitor blood sugar levels during study, observe for signs of hypoglycemia, diaphoresis, and somnolence, which is basically tiredness, and provide a snack such as cookies and juice at the end of the test. Now, what is growth hormone deficiency? Now, growth hormone deficiency can be called hyperpituitarism or dwarfism, which is an inadequate secretion of the human growth hormone by the pituitary gland. Now, the pituitary gland is excreted throughout the day, with the most excreted at night. So it is excreted in the day, but mainly at night. It impairs the ability to metabolize protein, fat, and carbohydrates when the growth hormone is too low. It's typically noted by the second year of life because when they are born, they fit into these normal parameters. So when they're around 2, we start seeing this. How will we know? Well, they're going to have poor growth, short stature, and their height is going to be less than the 5th percentile for their age and gender. Know that. Know the diagnosis, know the clinical picture, that it's going to fall off the growth curve, okay? The growth, you're going to have to measure them over an extended period of time between 6 and 12 months of age. Also consider the height of the parents, right? If they're shorter parents, this child may not be so strong. Like not strong, and they may not be so tall. Things that we want to think about is first, we're going to look at x-rays to assess the growth plates of the wrist. And then the second thing that we're going to do is laboratory tests. These testings include thyroid function tests, CBCs, electrolytes. Normal thyroid function is needed for adequate growth. That is why we have that as a second test. But the first test is going to tell us about the growth plates, right? Are the growth plates of the wrist, right? Those epithelial plates, are they good, right? If there's something wrong with those, we know that impairs growth. Now, for the growth hormone stimulation test, we kind of talked about that over here. It's also chart 48.1, but just to go more into it, after we get the lab, so first we do the x-ray, then we do the labs. After all that, then we'll do a growth stimulation test, or sometimes called a pituitary function test. So what we do is we give administration of a stimulating agent, such as insulin, glucagon, arginine, clonidine, levodopa. And then after we give that, if the growth hormone level is less than 7, between the 7 to 10 range, if it's less than that, it indicates growth hormone deficiency. So less than 7, not good. But we need 2 confirmatory tests for this diagnosis, which means we do the test twice. So the growth hormone is secreted in pulsatile spurts during a 24-hour period, and it's not consistent. So you give it at different times during, the course, and we're trying to see if that growth hormone is going to still be under. Now, if it is under, we've confirmed it with the 2 tests. We're going to do what we call a growth hormone replacement therapy with synthetic growth hormone, what we call somatotropin. You can find this on page 1781 in your textbook. It's a subcutaneous injection 7 times per week, usually at bedtime. Know that. And know that it's continued until the child's growth plate closes or the child reaches an acceptable height or predicted final height. If you don't know anything, I would know this for the growth hormone, right? Especially somatotropin. I know she asked about that. So you can go to the little chart. I would read that over. In addition to that, nursing management includes reviewing the growth charts, assessing the height every 3 to 6 months. Know that. And the goal is at least 3 to 5 linear inches in the first year of treatment. Early diagnosis is better. Enhance self-esteem through positive feelings, things like that. And we need to monitor blood sugar and electrolytes while on growth hormone, because growth hormone causes metabolic issues. Know that as well. Education also includes to report any headaches, rapid weight gain, limping, complaints of joint pain, or slipped, I can't say that word right now, episis, which is hip or knee, like a slipped hip or a slipped knee. And success really depends on how well they adhere to the regimen. But make sure to know for the medication that they need to report headaches, rapid weight gain, limping, or complaints in the joint pain or a slipped pieces, hip and the knee, okay? So you need to know that. She does ask a few questions, especially on this, but I think that's it. Is there any questions?